Hello and welcome to this session on interpretation of products of conception for pathologists online. I'm Fabiola Medeiros. I'm the Director of Gynecologic, Placental and Perinatal Pathology at Cedars-Sinai Medical Center in Los Angeles. In this session, we're going to cover histology, missed abortions, molar pregnancies, and causes of recurrent pregnancy losses. Starting with histology. Histologically, POC is comprised of the elements listed here. So that you're familiar with names, chorionic villi have an outer layer of syncytial trophoblast, an inner layer of cytotrophoblast that envelops the villus stroma that contains fetal capillaries, and in normal pregnancies at least there are nucleated red blood cells within those capillaries. And then we have the trophoblastic cells that are not syncytial or cytotrophoblasts that are called extravillous trophoblasts. In the past, those were known as intermediate trophoblasts, but now the preferred nomenclature is extravillous trophoblasts, and there are two subtypes, interstitial and endovascular, and finally the decidua. Now we're going to move on to the slides, the virtual microscopy, and we'll be looking into these components. We will start with this case that is actually a tubal pregnancy, and the reason for that is because this is the earliest normal POC we usually get. So this one is less than 6 weeks, and the reason why I know that is because if you look at all the villi, none of them have capillaries, and capillaries form at 6 weeks. So this is below 6 weeks, and it's a good example of very early POC. So what we have is the villus stroma in the center, which is this myxoid blue stroma here. And then we have this layer here of cytotrophoblast that is more internal, and around it we have the syncytial trophoblast, which is the syncytium of larger cells right here. And as you can see, the cytotrophoblasts actually give rise to both syncytial trophoblast and extravillous trophoblast. And this is one area here where we see where the cytotrophoblast is growing out of the villus with some syncytial trophoblast as well. And this is where the POC is trying to implant in the wall. So all of this here is where basically the trophoblast is growing out of the villus to form the implantation site. Of course, this is a tubal pregnancy, so we are not going to be seeing normal implantation in this case. Now we're going to move to the second case. This is a elective termination at 8 to 9 weeks. And here we start seeing already lots of capillaries within the villus stroma, and these capillaries contain abundant nucleated red blood cells, so we see that here. And also here we see a very nice layer of cytotrophoblast and then syncytial trophoblast more outer. And also throughout the first and second trimester there is another cell type that I didn't list but that we can see nicely here. These are histiocytes, all these cells I'm pointing, and those are called Hofbauer cells, and they are the resident histiocytes of the placenta. Actually, they are present throughout pregnancy, but later on in the third trimester, the villi become fibrotic, and then you can see them very well. But in first and second trimester, the villus stroma is either kind of myxoid, loose like this, or edematous, naturally edematous, and so you can see them quite well. Now let's take a look at extravillous trophoblast. So as I said, there are two subtypes. Let's first look at the interstitial type. Interstitial type extravillous trophoblast is the one that forms the implantation site. So what is implantation site? Implantation site is a mixture of extravillous trophoblast, fibrin, fibrinoid, and decidua. So fibrinoid is the material that is secreted by the trophoblast. Fibrin is from maternal blood. They mix up throughout the placenta, and we have very nice here lots of fibrin and fibrinoid, which is more like bright pink material. And then we have these atypical cells, right? All the atypical cells we're seeing with hyperchromatic irregular nuclei are extravillous trophoblasts, while these cells here at the bottom, or those at the top, right there, those are decidual cells. Decidual cells have a much more regular nuclei, with open chromatin and a small conspicuous nucleolus. So all of those I'm pointing are decidual cells, while these big ugly guys here are all trophoblastic cells. And then we have the endovascular trophoblast, extravillous trophoblast. So let me show you what happens to the vessels at this stage in pregnancy. So in some areas on a POC specimen, we're going to have these arterioles, which are the spiral arterioles of the endometrium. And they look pretty normal, right? They have muscular walls and a constricted lumen. But this is in contrast to this area here. Believe it or not, those are also the same vessels, the arterioles, but now they're being modified for pregnancy, and that's achieved by invasion of the vascular wall by these endovascular extravillous trophoblastic cells. They invade the wall, they destroy the muscle, they replace the muscular wall with fibrin, fibrinoid, and they actually invade the muscle wall. They also replace the endothelial cells, and early in pregnancy they plug the vessel lumens, as you can see here, and that's to control the flow of blood to the very delicate still gestational sac that is forming, and the embryo that is forming. So those are the histologic components of a normal POC. Now let's move on to missed abortions. So missed abortions have two main subtypes. Usually you're not able to tell them apart based on microscopic examination, but in general we can separate them in karyotypically normal and karyotypically abnormal. So karyotypically normal POCs in missed abortions, they can either be developmentally abnormal or developmentally normal. The prototypical developmentally abnormal POC with a normal karyotype are anembryonic pregnancies that are also called blighted ovums. There are some cases, of course, also of anembryonic pregnancies with abnormal karyotypes, but most commonly they have normal karyotypes. If the embryo, the pregnancy is developmentally normal, you have two other subcategories. You can have those without evidence of an active maternal disease process and those with evidence of an active maternal disease process. We are going to cover some of those later on in under recurrent pregnancy losses, but basically if there is nothing that you can see in the POC that indicates an active maternal process, that doesn't mean that there aren't maternal factors that are in play. So low maternal age, like very young mothers, late maternal age, smoking, diabetes, and even in vitro fertilization are risk factors for missed abortions of developmentally normal, karyotypically normal missed abortions. So the first one I'll be showing on the slides are anembryonic pregnancies. So because there is no embryo, capillaries do not form, and therefore there is a problem with exchange of fluids within the villi, and they all become, like, all villi become hydropic and enlarged, and by hydropic I mean edematous. And of course you should have no nuclear red blood cells and no embryonic tissue. But the most common scenario you're going to see under the microscope when we look at missed abortions are involutional changes. So in involutional changes, we're going to see these features that I'm going to show on the slides. Villous edema, also known as hydropic changes, myxoid degeneration, increasing perivillous fibrin, cellular debris, and villous fibrosis. So let's start with an anembryonic pregnancy. This is a very classic case. We see that all the villi are enlarged and all of them are edematous. However, I mean, this is a main differential with molar pregnancy. We don't see trophoblast proliferation, for example, we don't see cisterns, we don't see some other features that makes us worry about molar pregnancy. Instead, the villi tend to have pretty smooth outlines, and as you can see, none of them have capillaries. So capillaries and nuclear red blood cells are absent. They're very edematous. They show this myxoid degeneration as well. Trophoblast is normal. There is no increase in trophoblast. So this is pretty much a very classic picture of an anembryonic pregnancy. Now let's show some involutional changes. So that's when the POC is retained in utero. So let's see what we're going to see here. So one of the difficulties is when the POC is retained in utero, the first thing that closes up are the vessels actually. So when we look at this case of a missed abortion, we actually see that a lot of the villi do not have open vessels, right? So that may make you think of an embryonic pregnancy, for example. But then we start seeing nuclear red blood cells. So when you have nuclear red blood cells, basically it means that there was an embryo, right? And another thing we're gonna see is this karyotypically debris. So you see here how we have some debris, karyotypically debris in the, I think most of those are actually endothelial cells. So that's one example of a missed abortion. Let me show you another example of a missed abortion. So this one has two other features that we see. It has this myxoid degeneration. So you see that the stroma is replaced by this myxoid degeneration, and notice also there is like necrosis of the trophoblast. And here, this is a more advanced retention in utero, so we have increased perivillous fibrin as well, which are with this material. And again, looking closely, we see that the trophoblast is pretty much necrotic, vessels closed. So this here is another example of a missed abortion, and in this area here we have more debris and more villi without open vessels, even though in some other areas we do see some open vessels with nucleated red blood cells. This is a more advanced POC, greater than 10 weeks, and at this gestational age, one thing that you're going to see as degeneration is fibrosis. So we start seeing that some of these villi look more like pink. You see, they are not so loose anymore. The stroma is not so loose. So this here is an example of a later missed abortion with villous fibrosis. In general, it's not easy to characterize these findings under the microscope. One of the reasons is because elective terminations sometimes are terminated via medications, and those can cause very similar findings to retention in utero. So again, not an easy differentiation to make under the microscope. Now let's move on to missed abortions or even elective terminations of POC that are karyotypically abnormal. So multiple studies have been showing for decades now that at least 50% of early pregnancy loss, and that's defined at less than 14 weeks. So up to 13 weeks is early pregnancy loss. At least 50% is due to chromosomal abnormalities. However, most of these chromosomal abnormalities are actually lethal. And a lot of them, the great majority of them are sporadic. So it's actually reassuring to have an abnormal karyotype in a missed abortion, because it means it's likely a sporadic event and not a recurring event. Amongst the chromosomal abnormalities, trisomy 16 is the most common and it's lethal. The second one is monosomy X, that is often lethal, but sometimes, as we know, Turner syndrome, some patients are born alive and actually go into adulthood, and a lot of those are mosaics. And then triploid pregnancies, we're going to discuss more about triploid pregnancies later on when we discuss molar pregnancies. The interesting thing about these POCs with abnormal karyotypes is that only a small proportion of them, like 30%, actually show abnormalities of the villi under the microscope. And we call those abnormalities dysmorphic features. While 80%, amazingly enough, you have an abnormal karyotype, and they can look completely normal under the microscope. So bottom line is, you cannot distinguish a normal karyotype from an abnormal karyotype on POC examination under the microscope. Of course, if there was a karyotype done, for example, prenatally by chorionic villus sampling or amniocentesis, and I know this is a trisomy 13, for example, in my report, I'll usually say chorionic villi with dysmorphic features. But if I don't have cytogenetics in the case, I will refrain from making this call unless it's absolutely obvious. And some cases are absolutely obvious. So what do we see under the microscope? Under the microscope, we're going to see features that you're very familiar with, because they're basically features that we see in molar pregnancy. Because of course, both partial mole and complete mole are either chromosomal or genetic abnormalities within the POC. And if we are outside of molar pregnancy, we still see very similar changes, but we see them to a much lesser extent. So they're less obvious, they're more focal. And that's one of the reasons it's not easy sometimes to detect, for example, a partial mole right under the microscope, because just dysmorphic villi of trisomies, for example, look very similar. Some of them may look similar to a molar pregnancy. So what are the features that we're going to look we'll be looking for under the microscope? Is villus enlargement, irregular villus contours, trophoblastic hyperplasia, trophoblastic inclusions and pseudo-inclusions, nucleomegaly of the stromal cells within the villus stroma. And cisterns are quite rare, actually. We rarely see it. It's more common in molar pregnancy. And abnormal vascular parents is something that I think most people don't actually take too much into consideration. So we're going to start with this case of trisomy 11. So we know this is not a mole, even though you may consider a mole a partial mole. And again, features are very subtle, so don't worry if you can't get them at first. It takes a lot of experience at looking at POC to see any of those changes. So these are dysmorphic villi, in my opinion. And what makes them dysmorphic? Well, first of all, we have some villus enlargement, like this villus here. One of the main characteristic features is irregular contours. And how do I tell? Well, you see how the trophoblast is kind of growing in the villus right here. So that's the type of irregular outline you want to see. You also see these knobs. You see, like, the stroma is kind of growing out the villus in a way, like here too. So when you start seeing a lot of it, you start suspecting this is potentially dysmorphic. And then we have trophoblast inclusions, pseudo-inclusions. This is an example here. So what's the difference between trophoblast inclusions and pseudo-inclusions? Pseudo-inclusions are supposed to be just tangential cut of the irregular villus outlines. And real inclusions are believed to occur because there is true trophoblast proliferation. So you see this area here, it looks like the trophoblast is growing in. And here we have maybe a pseudo inclusion right there. And not only that, we have more trophoblasts than usual. So first, we have lots of syncytial sprouts, but this is not a stage in pregnancy where we should see this many syncytial sprouts of syncytial trophoblastic cells. And also notice that they're not polarized. They're not polarized towards one end of the villus as we see in early pregnancy. And instead, they're kind of haphazardly growing. And that's because this POC is karyotypically abnormal. So the villi are not normal. But again, very subtle. Features are there, but quite subtle indeed. But we don't have cisterns, we don't have super enlarged villi, we don't have lots of trophoblast proliferation, but you can see these little knobs coming out of the villi. So these are just morphic villi, and that's a case of trisomy. Now let's move on to molar pregnancies, and starting with partial mole. Most partial moles present as missed abortions at late first trimester, and that's a challenge both for clinicians and pathologists alike, because a lot of the features that you see clinically and pathologically in partial mole is shared with missed abortions, including beta HCG levels and the microscopic appearance. So keep that in mind when looking at these cases. Partial moles are defined by diandric triploides. Tetraploid partial moles do exist, but they are exceedingly rare. There are also tetraploid complete moles, tetraploid normal pregnancy. So when you start doing a lot of cytogenetics, as we do here, you start coming across these more unusual patterns. But for you in general, what you have to remember is that they are triploid, and you basically have one chromosomal complement from mom and two from dad. So that's why diandric is two dad and the other part of the triploidy is mom. And the most common karyotype would be 69XXY. So that's partial mole. However, there is a proportion of triploid pregnancies that are not molar, and those are called digynic triploidy. And those are the ones in which you have two chromosomal complements from mom and one chromosomal complement from dad. And those cases don't have the typical histologic features that we see with partial mole. They have more like a dysmorphic appearance, very mild microscopic abnormalities that you're probably not going to be able to pick up, and you're most likely just to call that normal under the microscope. Because it is so challenging to differentiate dysmorphic villi of other chromosomal abnormalities from partial moles, it is important to use ancillary tests that can be either based on cytogenetics analysis or molecular testing. You can use any of these modalities that I'm showing here. However, genotyping is superior because it will help you define the complement of chromosomes, the origin. Do you have one maternal, two paternal? So the most, I think, widespread method is called short tandem repeat analysis, or STR, which is actually a quite simple genetic test, but most laboratories do not perform it. And then under the microscope, we're going to see features that are very much similar to what we saw in dysmorphic villi, and that includes villus enlargement in irregular contours. Also characteristically in partial mole, we have two populations of villi, some that are large and edematous and others that are small and fibrotic. And then we have trophoblast hyperplasia, trophoblast inclusions, pseudo inclusions, and cisterns. So let's look at some slides under the microscope. This is a partial mole confirmed by flow cytometry as being triploid. And what strikes you right away is this huge villus with a huge cistern in the center. Honestly, if you see something like this, you should ring bells like molar pregnancy. And because we have a lot of villi in the background that are much smaller, as we can see here, this is not really consistent with a complete mole, because in complete mole, all the villi are enlarged, while in partial mole, only some villi are enlarged, like we see here. And of course, we have lots of capillaries with nuclear red blood cells, so pretty much by definition, that was an embryo. There are some rare case reports of twin pregnancies, one molar, one non-molar, but honestly, that's very rare. So I don't think you need to worry about that much. So if you see nuclear red blood cells, more likely than not, it is going to be not a complete mole, let's say. And here we see some other enlarged villi right here, right? We saw the cistern. One funny thing, and here we have the irregular villus outline. So remember that I showed you for dysmorphic villi that these indentations here are kind of characteristic. So we see that there, we see that here as well, okay? So we see both of them. So this is a partial mole. This is something you're going to look under the microscope and say, oh, this could be a molar pregnancy. And then you're going to do whatever test your institution provides. And if it comes back triploid, they're pretty much done because you have histologic features and you have also confirmation by ancillary studies. This is another partial mole. The difference is that this one has more degeneration. So as you can see, some of the villi have that myxoid degeneration that we described before, that we see as involutional changes. Some have increased perivillous fibrin, and this is because this partial mole was retained in utero for longer than the first partial mole that I showed. And that's one of the difficulties with molar pregnancies, is that involutional changes tend to confound the interpretation, and what you see you may be interpreted as involutional changes, actually molar changes. So it's kind of difficult actually. But again, in this case, we have some villi that are significantly enlarged. This is the lowest power. So as we go closer, again, we see that double population. We have those small villi that are fibrotic in the background, and we have this big edematous villi with cisternae. And here we have trophoblast proliferation. So look at this villi. They have all this syncytial trophoblast growing out for no reason, and that's called lacy trophoblast proliferation. It forms like a lacy appearance, and it's just growing out of control. This is not an orderly trophoblast proliferation as we see in normal pregnancy. Of course, when we move on to complete mole, it's going to be much more marked, but in partial mole, depending on the case, you're also going to see it, and I'm showing that here. So let me see if I can find maybe more trophoblast inclusions or pseudo inclusions. I don't see many. They're usually focal, but that's something you can definitely look for. Here is one. You can look for, so that in the center, probably trophoblast pseudo inclusions right here due to the irregular villus outlines. A funny thing that I find by looking at POC is that partial moles look different. So one partial mole has some features and not others. Some other partial moles have some features and not others. So you really have to look for every feature. Not every case will have all the features, and plus findings tend to be focal. So for example, this one has what we call, in this area, has what we call polar trophoblast proliferation, where trophoblasts growing only one side of the villus, and that's normal. So you may look at this and say, oh, this is normal. But then when you look in other areas, you see that there is an inappropriate increased trophoblast proliferation. So again, very difficult. We do not recommend that you make this diagnosis without ancillary testing. Complete moles. Unlike partial moles that are usually just a missed abortion, complete moles are nowadays pretty much always clinically suspected because the patient has unusually high beta HCG levels and abnormal ultrasound findings, and one of them, they see actually the enlarged villi as vesicles in the ultrasound, and there is an absent embryo as well. And the great majority of complete moles are diploid and diandric. Again, we see similar features as partial mole, however, they're much more pronounced. Okay, so we see diffuse and marked villus enlargement, irregular villus contours. Trophoblast proliferation is very obvious, it's circumferential, it's very marked proliferation. We see cisterns. One feature that we see too is blue myxoid stroma. It kind of reminds us of that very early pregnancy at 5-something weeks that I showed as the first case, but here they become even more blue myxoid stroma. They have lots of apoptosis and atypical stromal cells. We should have no embryo and no nuclear red blood cells. And in addition to that, the extravillus trophoblast tends to be quite atypical. Trophoblast is usually atypical, but here they become even more atypical. And that's a phenomenon that is seen in 2/3 of complete moles and about 10% of partial moles. Complete moles are very obvious under the microscope. Villi are very large, very, very large. Again, this is the lowest magnification, and we just see very large villi everywhere. We see lots of trophoblast, and this here is a prototypical circumferential trophoblast proliferation here and here as well, just out of control. Trophoblast proliferation everywhere, very large villi, very regular contours on this villi. We have cisternae right there in the center, and when we look closely at the villostroma, first we see no capillaries or red blood cells, but then we see lots of apoptotic debris. I'm not even sure if that's apoptotic debris or is artifact. Some of it is artifact. But we see that the villostroma is has these atypical stromal cells, and this is true apoptotic debris right here. And we also should see trophoblast inclusions and pseudo inclusions. Let me see if I can find one here to show you. But despite the fact that you don't really need ancillary tests to diagnose complete mole, immunohistochemistry for P57 is used in many places, and it is helpful. For a diagnosis of complete mole, what you want to see is loss of nuclear staining in the stromal cells and cytotrophoblast, while syncytial trophoblast, extravillus trophoblast, and decidual tend to be positive. In our laboratory, syncytial trophoblast is negative, but in many laboratories, syncytial trophoblast will be positive. But as far as we have negative staining in stromal cells and cytotrophoblast, it's good confirmation of a diagnosis of complete mole. Now let's talk quickly about recurrent pregnancy loss. The definition of recurrent pregnancy loss is greater than 3 spontaneous pregnancy losses in the first or second trimester. It's important to keep in mind that 90% of early pregnancy loss are sporadic in the first trimester, and only 5% are recurrent. Main causes of recurrent pregnancy loss are chronic histiocytic intervillositis, massive perivillous fibrin deposition, and chronic or plasma cell villitis and deciduitis. And these are things you should be looking for in POC examination, particularly in the setting of recurrent pregnancy loss. Let's start with massive perivillous fibrin deposition. There are a couple of maternal associations that are quite important and we see often, and those are maternal thrombophilia and antiphospholipid syndrome. This is a condition that is associated not only with recurrent missed abortions, early pregnancy losses, but also later on in pregnancy, in the second trimester, for example, with high perinatal morbidity and mortality. The recurrence rate varies widely in the literature from 12 to 78%. In my experience, in our experience here, it's towards that higher percentage. When we talk about placental pathology, the mature placenta, there are quantification criteria like more than 50% of perivillous fibrin deposition in one section, or more than 30% of the entire placenta. And then there is also a related condition called maternal for infarction. It happens mostly at the near the basal plate. None of those actually apply to POC, and in fact, the interpretation in POC is more difficult. First, because you don't have the gross appearance, you can't really see it grossly in a POC. And second, because POCs are fragmented, so quantification is difficult. But I think the main reason why this is missed, and I have seen this diagnosis being missed on POC, and the patient sometimes has 5, 8 missed abortions until someone actually sees it under the microscope. The main difficulty is the fact that retained POC, those involutional changes, can have increased perivillous fibrin, and also some drugs used for induction can cause increase in perivillous fibrin. So it's not an easy diagnosis to make under the microscope, but I'm going to show you a case that is quite convincing in POC. So we're going to see how that looks like. The second condition I'm going to show under the microscope is chronic histiocytic intervillositis. This is a major cause of recurrent pregnancy loss, and this is something quite straightforward to find in microscopic examination. So I'm also going to show you an example, and hopefully none of us will miss this condition, which recurs in up to 50% of pregnancies, and is again not only associated with recurrent early pregnancy loss, but also high perinatal morbidity and mortality. Starting with massive perivillous fibrin deposition, this is a case of a young woman that had 9 recurrent pregnancy losses in the first trimester, and all of them looked exactly the same. So what we have here are immature villi, as we see in POC, but notice we have a lot of perivillous fibrin. A lot of perivillous fibrin. Everywhere we look, we have perivillous fibrin. Okay, look at here. So as I said, you can see very focal increase in perivillous fibrin due to retention, but usually in those cases the villi will show degenerative changes, while these villi here show no degenerative changes. They're very normal looking villi, right? Look at the vessels, very well preserved, minimal, if any, involutional or degenerative changes. But while there is a lot of perivillous fibrin, so there's this massive perivillous fibrin deposition diagnosable on first trimester POC specimen. You may not need to actually headline your diagnosis like that, but at least say like immature chronic villi with marked increase in perivillous fibrin. This diagnosis should be clinically considered if this is a recurrent pregnancy loss. And there are actually some treatments that clinicians can use. In this particular patient, thankfully, she did have a term pregnancy. They use a lot of immune suppressors. I don't know exactly which type of medications they use, but they can try to take this pregnancy to term. And then finally, chronic histiocytic intervillositis. I don't actually have a POC with that. I only have a mature placenta with that condition, but that will give you a sense of how it looks like if this was a POC. But this again, it's a mature placenta, but in POC would be a similar kind of picture. And what you would see is in between the villi, you see increased perivillous fibrin as the other condition we discussed, but in addition to that, we are gonna just like a lot of histiocytes, collections of histiocytes. So that's what we see here. The intervillous space should only have maternal blood. It should not have lots of fibrin. It should not definitely have lots of inflammatory cells. If it's chronic inflammatory cells, it's usually chronic villitis, acute inflammatory cells, acute villitis and intervillositis, but in this case, this is chronic histiocytic intervillositis. And the immunostain you can use to confirm your diagnosis if you want is CD68 or any histiocytic marker. And it's beautiful in this case. You can see how many histiocytes we have here in the intervillous space. So these are 2 conditions that you should be able to pick up on POC examination. So that closes our session for products of conception. I hope you have enjoyed it and learned from it. Thank you very much.